This has been an unprecedented time, the pandemic, but then the decade that preceded it was not great either. My own involvement in thinking about well-being of children has gone on for some time before that. In the WHO Commission on Social Determinants of Health, which I chaired, in our report in 2008, our number one recommendation was equity from the start. Give every child the best start in life. And then with the Marmot Review, Fair Society, Healthy Lives, that followed on from the WHO Commission, number one recommendation was give every child the best start in life. In our 2020 report, our February 2020, looking back on what had happened in the previous decade, we pointed out that child poverty, which after housing costs in 2010 had been at around 27%. In other words, 27% of children were growing up in families at less than 60% median income. That child poverty level went from 27% to 30% over the decade. There were some lies told in Parliament, regrettably, that child poverty had gone down. And I was sitting looking at the government's figures showing child poverty had gone up. And that, of course, is going to make it much more difficult for children to develop well if they're growing up in poverty, less than 60% median income. And that's the context, that's the challenge. I don't think we should see services for young children as picking up the pieces that were left by damaging policies that left more children in poverty. What we want are policies that are aligned, children growing up with better opportunities, afforded by better circumstances, and then addressing the question of what can this new approach to integrated care services do. Personally, I've been arguing that the key determinants of health lie outside the healthcare system. The conditions in which people are born, grow, live, work, and age, and the structural drivers of those conditions of daily life are the key determinants of health and health inequalities. But who cares more about health than people working in the care system, the integrated care system? And so then the question is, well, what can integrated care systems do to address the social determinants of health, as well as providing good care for those that need it? I, in my 2010 review, coined the rather awkward phrase, proportionate universalism. I said we wanted universalist systems with effort proportionate to need. And it was an attempt to marry the classic targeting approach of Anglo-Saxon policy, spend the money where it'll do the most good, target the worst off, with a more Nordic approach to universalist systems. So it was an uneasy compromise of trying to bring a a universalist approach and a targeted approach together. But then that's what the NHS is. It's a universalist system available to everybody with effort proportionate to need. Now, need in the NHS is defined on the basis of clinical need, but if we defined on the need on the basis of social need, I would argue we want universalist systems with effort proportionate to need. A seminar I was doing before this one, I was asked, was there evidence to support it and that it works? I said, well, the NHS is doing it. They tell me in France they're doing it all over the place. but I'm looking for the evidence. But as we think about what integrated care systems can do, I would hope to address the wider social determinants of health, we would think about it in the context of proportionate universalist systems, leveling up the gradient, because we know bad outcomes are not confined to the poor and okay for everybody else. They follow a social gradient. The greater the deprivation, the worse the outcomes, whether it's early child development, prevalence of mental illness, healthcare problems in children. They follow the social gradient. So that the universalist element is trying to deal with the whole gradient. The proportionate universalism is effort proportionate to need. So personally, I'm particularly interested in this afternoon's discussion. People all around the country are asking, how can the opportunity provided by the development of this new approach, ICSs, integrated care systems, be put into practice to improve the health of local communities and, I would hope, to reduce inequalities, create greater health equity. So that's my particular approach. It's important right now because the pandemic exposed the underlying inequalities in society and amplified them. And it's clear to me that ideally what we need is central government, city, local, regional government, the non-governmental organizations, civil society, such as Barnardo's, and integrated care systems, all working in concert to deal with these long-term problems that have been made worse by the pandemic for all the reasons we all know about. I hope that the audience will get engaged. Please use the chat function to address questions to the speakers, either to specific speakers or to in general, and we'll try and get people to respond. So put your questions and comments in the chat. Do get engaged. And with that, I'd like to kick it off by, I mentioned Barnardo's, who are sponsoring this, and Rukhsana Kapasi. By the way, I'm not going to give 10-minute spiels about each of the speakers because they only have 10 minutes. She's Director of Health at Barnardo's and will give us a vision for future ICSs for children and their families. Rukhsana.
Thank you, Sir Michael, for that context setting, and it's a real privilege to have you here chairing this seminar. For those of you who don't know, Barnardo's is the largest children's charity, and we operate right across the UK. And our size and scope really gives us a breadth and depth of understanding of children, their needs and their vulnerabilities, but also the ability to work on system-wide approaches collaboratively with partners to tackle health inequalities. Out of the 359 children that we supported last year, we provided services to over 100,000 children and families through our 72 children's centres and family hubs across the UK. And you can see from the map that our work in child and family health is very diverse. We provide a range of services from targeted counselling support for perinatal mental health to co-delivering child and family wellbeing integrated care contracts with partners across a geographical footprint. And we are very fortunate to have a pulse on what children's needs are and how families are coping through our quarterly practitioner surveys across our 800 plus services. And I think having this early insight into emerging needs has really enabled us to respond early, For example, last year we mobilised a national service called See, Hear, Respond in 4 weeks, and it was a partnership with the Department of Education to really meet that hidden need when schools and services were closed. And we provided interventions and support to over 100,000 children and families over a 9-month period. So Michael has highlighted why that focus on early years is so important, because if we get it right at the beginning of a child's life, we will really close the gap on inequality for the rest of their lives. And the evidence and the impact that we can make is quite compelling. But we have known for some time now that the child and family health system has really struggled to meet the huge challenges it faces. And as has been highlighted, the last year's really exacerbated some of those system-wide inequalities. The last 18 months have been tough for families and have taken a toll on children's health and well-being. So as well as the huge increases in mental health issues, we've seen waiting lists grow for services like speech and language therapy, diabetes care, autism assessments, to name but a few. And nationally, last year, 61% of health visitors reported an increase in child neglect, and 4 out of 5 reported an increase in perinatal mental health issues. The system has always struggled to shift spend from crisis intervention. In fact, funding for early intervention services has dropped by 48% since 2010. There is a human and economic cost to all of this, which is huge. And if we look at, for example, severe obesity rates for children living in the most deprived areas of England, they are 4 times those living in the least deprived, putting those children at risk of osteoarthritis, heart disease, stroke, diabetes, etc. So the formative work that you have done, Sir Michael, and others have really highlighted that if you are living in poverty, it will lead to worse health outcomes, a reduced life expectancy, and put you more at risk of substance misuse and smoking. And if we look at the economics, we spend a staggering 17 billion every year on preventable health and social care issues. We've been trying for some time now to really reform the system in relation to children's health and well-being. And most recently, Andrea Ledsam's Best Start in Life review in 2021 for the government concluded and recognised, as did the work of the Marmot reviews, the crucial role that good care during early years can make in achieving better physical and emotional health outcomes. But are we doing enough? When we investigated the state of play in integrated care systems, we could only find 1 out of the 42 existing ICSs which had a dedicated lead for children and young people. Our vision in Barnardo's is really that all families and children are guaranteed a basic state of health and well-being. And to achieve this, it's vital that we work with our partners at the earliest point so that we can improve health outcomes across the life of a child. That linkage with housing, employment, environment will be essential if integrated care systems are to meet the challenges ahead and make inequalities a thing of the past. And the voice of children and young people must be at the core of this. And we're now going to hear from some of our service users and practitioners in our child and family health services. So if you can play the video, Rob.
I'm a single mum to 1 daughter and 1 son. I was forwarded on to Kirsty from Barnardo's by the school as I was struggling with my health, which was affecting my children and my family life. Kirsty has been an amazing support to myself and my children. She has made regular visits to my home and shown me new techniques and tips so that I can bond better with my children.
We worked with over 3,000 parents, often described as hard-to-reach parents, on our WhatsApp groups, or delivering our programs or workshops. We were able to reach those parents, and it was just wonderful to see them being able to move on with their lives, and it was so fulfilling to us as an organisation.
The families tell me that their children enjoy coming along to the sessions, and some of them have grown in confidence in their speech and their social interaction with other children.
I started volunteering with Barnardo's 2 years ago, just to give myself some confidence and a little bit of separation from my son who has additional needs. I wanted him to be able to receive care from somebody else while I could go off for a couple of hours and have some time to myself. After having some reservations about attending the group, I'm really glad I did. It's been a great source of encouragement and information which I otherwise wouldn't have had access to. I feel it also helps me on a personal level to know that I'm not alone.
At the time, didn't feel confident as a parent, and through the year that I had with my support worker called April, we did the Family Links programme, and it helped me gain a lot of valuable knowledge and tools that I've been able to maintain over the last year.
I'm a health and family support practitioner within the Essex Child and Family Wellbeing Service. Since our service became more integrated, I feel that the service has improved. We have school nurses on board, we have health visitors with us, we have healthy schools, we have healthy family support practitioners, healthy family support assistants, and we all work together to create the best possible outcomes for our families.
Shana, is that?
Yeah, thank you. So I'm just going to finish off now. If we are going to improve children's health and well-being and raise healthy children to become healthy adults, then the system must be designed to meet their needs. They are not an optional extra. And to level up children's health equality, we must move away from the current deficit model of preventing and treating the symptoms of ill health to an asset-based model where we are co-creating health and supporting the whole family in a holistic way at the earliest point. You will have heard on the news about the extra 5.4 billion that the NHS will get next year, but the NHS Confederation and NHS providers have estimated that the NHS frontline will need an extra 10 billion over the next 3 years to meet the service and backlog needs. This, together with the current workforce crisis, really highlights that we have to work in radically different ways. The voluntary and charity sector are a huge untapped resource, and you will hear from our services about our experience in Barnardo's, in that we are able to be more agile, community and place-based with enormous flexibility and creativity in how we can respond and work across boundaries. And I was really pleased to see the new guidance published 4 days ago by NHS England, emphasising how the VCSE sector can be embedded in governance and decision-making structures in integrated care systems. I'll move on to my last slide. So I'll finish off now by saying that this is a pivotal moment in the history of the NHS where we can create shared value and responsibility to tackle the root causes of ill health at a place-based level. We have a huge opportunity as leaders in how we set up and run integrated care systems. To do this, we need to be prepared to take risks, to do things differently, to invest upstream so we don't build bridges downstream, and ensure that the needs and voices of children are represented at every level within the new ICS structures so we can build back better. From a Barnardo's perspective, we would like to set a challenge to every integrated care system to undertake a child impact assessment. Thank you.
Roxana, thank you very much. I said at the beginning that I personally need to have more to do with Barnardo's because of what you're doing, and what you've shown us, very important. We now go to the heart of it all, is that right? To NHS England and improvement. Matthew Clark, who is a paediatrician who's worked at the front line here in Africa and elsewhere, is now the specialty advisor for children and young people. Matthew.
Thank you very much. Thanks, Sir Michael, and thanks very much for the opportunity to speak today. So, Sir Michael, I'm the National Special Advisor for Children and Young People at NHS England and Improvement. And what I want to try and do this afternoon in the few minutes that we've got is just talk through some of the high-level priorities for NHS England in terms of child health nationally. And also just to recognise, as Sir Michael and others have said, the limitations of the NHS in shaping some of these things. A large number of determinants of child health lay beyond the traditional boundaries of the NHS, but it's our hope that by working in a more integrated way with local authorities and local services, we can start to address some of those concerns. So really, just to take a little step back and explain how we've come to having a young people's transformation team within NHS England and Improvement. I think it's fair to say, since the inception of NHS England, which in the grand scheme of things isn't that long ago, children and young people hadn't been a very obvious priority for the organisation outside of some of the more specialist areas of paediatric intensive care, paediatric oncology, the sort of things that got a lot of focus. So when the NHS long-term plan was published, again, not that long ago, but because of everything that's happened in the last couple of years, feels like almost a generation ago, there was a really clear commitment within that to have a children and young people programme, and actually recognition that many of the challenges in children's health aren't really suitably tackled through an individual hospital, an individual GP surgery, that actually there are system issues that prevent children's outcomes being as good as they are. So I just want to, wait a second, just click my slides here. So essentially, just as the NHS England team and programme were coming together to start to deliver on some of these priorities, the COVID pandemic sort of engulfed us just as we were getting started. So by necessity, that was slightly shifted some of the work that we've done. But actually, I think really importantly, it felt to us that in many ways the COVID pandemic, and although COVID as disease obviously didn't, or thankfully hasn't affected children directly, the indirect impacts of the societal changes have been dramatic, and which Sharon and others have talked about that, and colleagues on the call will be familiar with that as well. So to a certain extent, we felt that it was just amplifying what we knew about already in terms of inequalities and poor outcomes, and made some of our work even more of a priority. So one of the diseases that we are focusing on quite strongly at the moment is on asthma, and asthma is by far and away the most common chronic disease in children and young people in the UK. And actually, for me, is a real test case of whether we've got ourselves organised as an integrated system to look after the most vulnerable. We know there's a dramatic social gradient in terms of children and young people from more deprived backgrounds have much worse outcomes. And if you're going to manage asthma well, there's lots of other, it's not just about giving inhalers in hospital, it's about a much more comprehensive package of care than that. And that's something I was talking about a little bit in more detail. Other bits of work really relate to the urgent emergency care settings, and we've been trying to think a lot about how as a system we can be much more responsive to the needs and anxieties of parents when they're acutely unwell. There's obviously A&Es that are obviously open at all times for everybody, but equally we recognise at times they're actually not the best place to support families and their children to look after them at home. So some work's been going on to think about ways that we could, about sort of observation scores that can help to identify children at risk of severe illness, and also to work quite closely with the 111 service, because increasingly parents use 111 as a source of advice. But actually, those colleagues on the call who work in A&E departments and paediatric departments will report to you that an awful lot of children and families as a result of phoning 111 are told to go to A&E, which actually in the immediate moment may be the right thing or may for that family, but in the longer term, in terms of providing support and allowing families to look after their children at home, is really quite unhelpful. So a lot of work going on there as well. Obesity, again, is a subject that doesn't need much introduction in terms of its relationship to child outcomes, and there was a specific commitment in the long-term plan, NHS long-term plan, that was really about the most severely obese children and making sure that therapy for all those children and assessments and support is available. But clearly that needs to be as part of a much broader societal effort to tackle obesity, because clearly that's where the real opportunity is. I just want to talk a little bit about data and informatics as well, because actually sometimes it can be quite difficult for to understand really quite how poor the outcomes are for children, and for systems and system leaders to really understand what's happening in their systems for children and young people. And because if you compare children and young people services to something like adult cancer, there's a huge apparatus around adult cancer, appropriately so. We have 2-week rates and other constitutional targets, which are reported on a great deal of detail, which I think often skews people towards the thing they can measure that they can measure it most easily, whereas many child health outcomes are much more subtle than that. So we've been working quite hard to think about what data streams are available and what we can use to really shine a light on the issues for children and young people. And one of the things specifically we've been doing is that the NHS at the minute is very focused on trying to restore services to pre-pandemic levels, and this is particularly tackling waiting lists, which colleagues will be well familiar with as well. And one of the things we're tracking this time is actually, is there any inequality in the restoration of services? And actually at the minute there's quite a reassuring picture, but previously we have just said, oh, well, what is the waiting list? How many children are on it? But actually what we're also tracking is, is the proportion of children from different social backgrounds varying. And at the moment, there's quite a reassuring picture. One of the big pieces of work we're doing around data is the National Child Mortality Database. And this is a subject that, and as Sir Michael was generous enough to write a foreword for in the most recent report. And again, I hope is something that's available that is familiar to people. And if it's not, I would direct you to it. But essentially, every child who dies in England there's a statutory requirement to report on that death within 48 hours. And then there's a more comprehensive data collection process that goes on to try and understand what happened, what the themes are, and what are preventable. And I think there's been that, and although thankfully children's deaths are incredibly rare, I think it's really important that we do continue to learn from every single one of those and look for very early warning signs that things are going wrong. And it was useful throughout the pandemic, and that again is a subject for another day, but actually just what I wanted to highlight, colleagues who haven't seen it, one of our most recent reports from that was Child Mortality and Social Deprivation, which is the report that Sir Michael wrote the foreword in as well. And I just wanted to show one slide that really, which I think probably tells you almost everything you need to know about some of the inequalities in health outcomes of children. And essentially, the lighter green they are, the least deprived you are, and the darker green, the more deprived you are. And really, if you look across the board for all deaths, medical, surgical deaths, congenital deaths, it's really only malignancy and trauma and suicide where there isn't a clear social gradient. And I think probably just to compound that, and this isn't data that I've got on the slide here, is that preventable causes of death, which again follows that social gradient as well. So that is a huge should be a wake-up call to all of society really, and some of the learning of that should be focusing how we think about organising healthcare and healthcare services for children and young people. Finally, I just wanted to spend a minute or so talking about the asthma programme. As I say, this is the priority for NHS England over the next year or two in terms of long-term conditions. And what we've really thought about here is there have been endless guidelines, evidence-based reviews, medical journals, nice guidelines telling you how to manage asthma. But really, nobody has managed to so far line the system up, because to manage asthma well, you need children to live in the right environments. You need the parents to be able to give the medication safely and effectively at home. You need the schools to be able to support children with their asthma, whether that's whether they're having asthma attacks or taking their medication during the school day. And then when children get unwell, you need to be confident that they're going to be looked after in hospital in an appropriate setting. And then really importantly, once they've been in hospital once, that actually prompts a medical review. And actually we think again about, is this child on the right preventive medication? Are there any other factors in this child's life that we could change to try and prevent them having asthma attacks again? So we are just finalising what we're calling our national bundle of care for asthma. And that will pick up all of these elements that are on the slide here. And again, when that's published in the next few weeks' time, we'd be very happy to share that with colleagues. But actually, I think the real crucial thing to this is no individual part of the health or care system can deliver this bundle on their own. It's about primary care, secondary care, so education, school nurses, health visitors, all working together. And we've also put some funding in to support this. So essentially, each integrated care system has funding to employ an asthma lead who will be specifically tasked with working across the whole system and trying to embed some of these changes over time. And again, just circling back to the thing about data, it's really important that leaders of integrated care systems have in their board papers outcomes for children with asthma with the same priority they would have for maternity outcomes, adult cancer outcomes as well, and thinking very clearly about how we can use the data to really shine a light on an area of child health that doesn't go as well as it could do. And I think if we can, and hopefully when we manage to organise asthma care in a truly integrated way, that actually paves the way for other chronic conditions and some of the other issues that we're trying to. So Michael talked about as kind of real issues for child health. So I think I will probably stop there, but obviously pick up any points of interest in the further discussion. Thank you.
Thank you very much. We do now have some time for Q&A. One of the questions in the chat was, who on earth was talking? I didn't introduce myself when I was talking. I'm Michael Marmot, so we dealt with that question. So please, any questions you have, put them in the chat. Perhaps I could start off, and could I ask both of you about the balance between mental ill health and physical ill health? Perhaps Rukhsana, how much of your work is related to mental ill health, how much to physical ill health? And I think, Matthew, what you told us had more to do with physical than mental health. Can we start, Rukhsana?
Yeah, certainly. In Barnardo's, we've got 158 health commission services, and out of those, 78 are around mental health support. And they have actually doubled in terms of volume over the last 2 years. So that just really reflects the need that's there in the environment. And interestingly, last year in our practitioner survey that we did, when we did a bit of a stock take in June, as kind of COVID had started for about 3 months, we found that 81% of our practitioners reported an increase in mental health issues that they were having to deal with and support families with, in addition to what they were already providing that service for, so right across the board. So we know that this is a huge issue, and we, have had a number of seminars in Barnardo's as well, specifically around mental health, where we've got children and young people to ask some of the questions, and they are really concerned about some of the areas like transition support, where they kind of feel moving from, the age of 18 into adult mental health services, that they fall off a bit of a cliff edge without much support. So we know that this is a huge area, and there's a real lack in terms of that early provision as well.
And we know, don't we, that half the lifetime risk of mental illness, excluding dementia, has its onset by age 14. So this is the right age group to be thinking about prevention of mental illness. Matthew, you didn't say too much about mental illness.
No, and that is, I think, probably that's a shortcoming of me, and probably the way that healthcare system has organised itself for quite some time. That there has been this divide between physical and mental health that has grown up. I mean, certainly before I started medical school, decades ago, where you have these sort of separate organisations that, in inverted commas, do mental health and do physical health. And we've tended to think about children and young people as either having physical or mental health problems, and actually that in of itself feels an increasingly antiquated way of looking at things. And actually, if you look at the ward at the hospital, I work down in Hastings on the south coast, and we have a sort of 16-bedded paediatric ward, and if you look back even 5 years, you would have found 15 or 16 of those children would have had clear physical health needs, as in infectious diseases, asthma, having their appendix taken out, this sort of thing. Whereas now, if I was to walk onto the ward this morning, I find a third of the patients have been admitted with a primary mental health problem, where either it's so severe they're unable to be looked after at home, or they have a physical component of that, perhaps if they've got anorexic or something and they're now so unwell they need to be in the hospital to be looked after. And so I think that we, and I, in my presentation, and probably as a professionals, we're guilty of, as I say, dividing the two up in a way that's largely unhelpful. I mean, I would completely echo your concerns about mental health issues starting in youth, and we see a lot of physical sides of that. You know, you can make an argument about things like obesity as well, being and other chronic conditions all being related to mental health as well. So I think there is a late but increasing recognition of this across the NHS, and there's a piece of work going on at the moment to try and pull together at a national level the children and adolescents mental health team and the children and people's transformation team, which is I'm a part of, which historically have been totally separate, into combined work streams, and increasingly thinking about where we can work together so that when children present in crisis to any departments in their life, they can have a more appropriate setting. But actually, again, this is something that I think as well-integrated care systems really have an opportunity to take a step back. But actually, the time to intervene in these children and people's lives is not when they're in crisis and A&E taking overdoses as teenagers. It's about whether your school nurse and your health visitors are picking up on these things early, whether school counselling services are there to support families. And we are a little bit late, but slowly, I think, starting to recognise that. And and certainly children and adolescent mental health services have historically been dramatically underfunded compared to physical health services. But there is a very clear commitment within the long-term plan to reaching parity of esteem. And actually, again, if I just look locally, the number of crisis support workers I think we have has doubled just in the last year as a result of that investment. So that money is actually turning into boots on the ground to support families and young people, but there is years more required to get to the level that's required.
I was thinking as you were speaking that if you're doing a lot, you wouldn't have need to tell us so much. And when you said at the end of what you just said, more is required, I was thinking, yep, that was the message. Yeah. I was thinking as you were talking, I introduced it showing my own prejudices, that I thought integrated care systems were an opportunity to take action on the social determinants of health. But Matthew, in what you presented to us, except at the very end, you said very little about influences on health outside the healthcare system. At the very end, when you were talking about asthma, you did talk about parental smoking, about housing, about air pollution, which are vital. But you didn't say much until that point. Are you missing a trick here? Should we be looking to the NHS England and improvement to be emphasising more about public health, including public?
I mean, I think it's a really difficult question. I think that NHS England, you know, we have a clear remit, which is one thing, and there are other, as an arm's length body in terms of delivering healthcare, and there are other government organisations, what was Public Health England, which has now been reorganised as well. And I think it's fair to say that the NHS sometimes struggles to work out exactly where we sit in that. What's our remit in terms of, you know, we're given money to deliver healthcare, and that has to be our primary focus. And I think certainly our previous chief executive was very clear about that. But actually, I think increasingly as anchor or keystone organisations or huge employers, we are recognising our role in that. And I think that with everything that we do, we need to at least be nudging. And I think this is as sure in climate change, we're thinking about a carbon dioxide, you know, a CO2 neutral NHS has wider societal impacts. I think you're right. We need to be using policy, but actually to influence things. But actually, increasingly, I feel that's perhaps as much a local issue as a national issue. But actually, if you have chief executives on integrated care systems, or you have chief executives of hospitals sitting with local authority chief executives, there has to be some recognition that there is, to stop the amount of demand that's required in one, the other has to do something, and there has to be some kind of risk pooling for that. And I think to a certain extent, you're absolutely right to push NHS England in that direction, but also I think increasingly we need to see that happening locally as well. So I very much agree with that it is a challenge to find our exact roles in the context of it all.
Rukhsana, there was a question in the chat about the transition. You mentioned the cliff edge when children become adults, adult services. And there was a question in the chat about the 14 to 19 age group. Is this an issue, the transition from younger than that to the 14 to 19 age group, as well as beyond? Rukhsana?
I think that we find that it is a real issue, and I think that with some groups of children that we work with as well, such as care leavers, who sometimes move around from kind of one physical location to another, who don't necessarily have access to even, you know, being registered with one GP at any one point in time. We feel that that kind of support particularly needs to be provided up to the age of 25. And I think kind of increasingly in terms of both that 14 to 19 age group, but also beyond that, we would really like to see, you know, services extended up to that 25 age group in terms of transition. You know, I personally have a child with a complex long-term heart condition, and from my own personal experience too, I think that that would be really useful to him, because he's got a supportive parent that can go to appointments with him, but not everybody has that.
And could I ask you about the other end? How early does Barnardo's get involved? Do you get involved after conception, pre-pregnancy? What age of child do you get involved with?
Yes, so we will actually be hearing later on from our Happy service in Bradford that works with parents whilst they are pregnant to do some of that work around kind of parenting programs, to look at kind of some of the evidence-based issues around high BMI, low birth weight, etc., to really see if we can make a difference. And we really feel that starting early, you know, at that pregnancy stage and earlier too, is the right sort of approach in terms of prevention and early intervention.
Good, thank you. And Matthew, you mentioned the National Child Mortality Database. I was really struck that if you could reduce the infant mortality level down to that of the best of 20%, we could prevent half the infant deaths. Now, I'm not going to ask you to put a figure on it, but how much of that could be done by the healthcare system, and how much needs action on the wider determinants of health?
Yeah, as you say, I think that's very difficult to put a direct a number on. I think there are plenty of stones left unturned from a healthcare delivery point of view to contribute to that. I think there is more we could do around some of the community health visiting side of things as well, and some of the conceptual support to families as well. So yeah, I think there is more work to do from the health side. But as you say, I think ultimately progress needs to be made on some broader social issues that are outside the NHS England's remit as well.
Thank you. Thank you both. A terrific introduction to the afternoon, really special. And now we want to move to Birmingham and hear about integrated early years health and well-being for children and families. Richard Kirby, who's Chief Executive Officer, Birmingham Community Healthcare, and Adam Cooper from Barnardo's. Richard.
Thank you very much, Sir Michael, and thank you for the invitation. As you said, my name's Richard. I'm the Chief Exec at Birmingham Community Healthcare, and I'm also the Integrated Care System Lead for Inequalities in Birmingham and Solihull. And what Adam and I would like to do just in the next few minutes is talk to you a bit about Birmingham Forward Steps, which is the partnership between My NHS Trust, Barnardo's, and a number of other providers of children's services to seek to deliver that proportionate universalism in early years services in Birmingham. There are just two things I'd like to say at the start. One is if I might take the opportunity just to pay tribute to all the colleagues who work in Birmingham Forward Steps for the fantastic way they've responded to everything that's been thrown at us in the last 18 months or so, as we've tried to come to terms with COVID-19 and what that's meant for children and families in our city. And secondly, I think just to recognise, though we're very proud of what we've done in Birmingham Forward Steps, we have by no means cracked this, and I'm sure there's lots for us to learn from other people here today, as well as something I hope we can share. So, our experience is offered in that spirit rather than as a kind of blueprint for necessarily how to get everything right, and I hope it will be received in that way. So, just a little bit about who we are. We're a few years old, though still relatively young in our kind of life. We're a partnership of an NHS trust and 4 major community and voluntary sector organisations, of which Barnardo's is a big part, working together to provide early years support from pre-birth to 5 years. And our mission, if you like, is to give every child in Birmingham an equal chance to have the best start in life. That focuses on child development and school readiness, on supporting parents with their aspirations and parenting skills, and on child and family health and life chances. And within it, we deliver a range of interventions from the, if you like, the kind of standard health visiting service right through to children's centres, family support workers, and a range of different kinds of support services delivered in partnership with a wide range of local organisations. And for those of you who know Birmingham, that's the kind of map. We organise ourselves into 10 districts. Those districts have very distinct needs. So there are parts of Birmingham that are amongst some of the most affluent communities in the country. There are very definitely parts of Birmingham that are amongst some of the least affluent. And one of the advantages we think of our model is an ability to tailor, working with local partners, a degree of delivery to match the needs and the situation of the people in the area we are serving. So the 10 districts are split across a range of partners alongside the core NHS service in each area. And to locate it a bit in the discussion about inequalities that's been running through some of what we've been talking about today. I mean, I'm a Birmingham resident and enormously proud to be so, but it can be a place in which many people are dealt a pretty tough hand. So 1 in 3 of the children in our city live in poverty. Well more than half of the population of Birmingham are in the bottom 20%. If you look at the index of multiple deprivation, that's we've well over 100,000 children in the bottom decile, and it plays through in a range of ways in terms of the disadvantage that children and families face in our areas and the kind of support we seek to organise to respond to that. And we, as I've said, we don't do that perfectly, but we try our best. And if you know anybody from Birmingham, they will probably say to you, Birmingham has more canals than Venice, it has more parks than Paris, but perhaps most importantly for today's conversation, we are the youngest local authority in, we think, Europe, and getting this right for our children and their families is therefore really important. I'm hoping that the technology next will permit us just to watch a short animation that describes what Birmingham Forward Steps offers to families, and then we'll hear from Adam about some of the work we're doing and what we're learning from it.
Birmingham Forward Steps supports young children and their families to help them make the best start to their journey through life. We offer help and advice to you throughout your pregnancy and beyond. We provide health and wellbeing services for parents and families and babies and children up to 5 years old. Our health visiting teams will routinely contact mothers and the family to offer health reviews and advice antenatally, during the new birth period, 6 to 8 weeks after birth, and when a child reaches 1 and 2 years of age. We have children's centres across Birmingham that offer baby groups, free baby massage, breastfeeding support, family support, stay and play sessions, and much, much more. Birmingham Forward Steps offers a variety of other services, including child speech and language development support, community engagement workers, healthy lifestyle advice, behaviour management, parenting programmes, events and trips, training and employment assistance, and online virtual support. If you live in Birmingham, we can help you and your child to develop skills and stay healthy. Birmingham Forward Steps is a partnership between the Birmingham Community Healthcare NHS Foundation Trust, Barnardo's Children's Charity, Spurgeon's Children's Charity, St Paul's Community Development Trust, and the Springfield Project. Take a step in the right direction and contact Birmingham Forward Steps for the best start for your children.
Thank you, and I hope that the tech will now permit us to hear from Adam Cooper, the director from Barnardo's, who's been working with us on this.
One of the things that's most important in order to achieve success, and we think is key in Forward Steps partnership, is integration. So when we talk about integration, it's really important to think about what that actually means. And I think key to that for us is that the families we support only have to tell their story once to one professional, and that after that they get the service and the outcomes that they need. And that is really hard to achieve, but really key to our success. So in terms of how we do that, the things that underpin that are shared training and resources, and a trained multi-agency staff team. So we're really lucky to have a team that includes both health, social care and early years education professionals working together every day in a coordinated way. I think that the combination of voluntary sector and statutory partners works really well, and it enables us to know our community. So I think that that's key to integration. And actually, in terms of BFS, in addition to the strategic voluntary partners that are in the partnership, so ourselves, Barnardo's, Spurgeon's and Springfield and St Paul's, we've got a whole multitude of other voluntary partners, both large, like Family Action, and a whole range of small grassroots partners that deliver specialist pieces of work and interventions and work together formally via subcontracts for specialist pieces of work and informally to achieve integration. So what does that actually mean in terms of achievements? So I'm just going to talk through what I feel really are our key achievements in the last 18 months. We're really proud of the rollout of integrated mandated development reviews across our partnership. So we started to look at the rollout of this in Q3 2020, and this particularly looked at delivery of the 2-year-old mandated development reviews and improvement around performance in that area. So from Q3, Barnardo's early years workers were trained and worked alongside health colleagues to deliver the mandated development reviews for 2-year-olds. It's been really successful to date. So we have moved from 51% completion of those checks in July 2020 to 78% completion in July 2021, which is massive growth. That actually exceeds the expected trajectory for the project, which was around 67% for this period, and actually is continuing to improve. So there's a lot of hard work going in there, but we expect to have achieved 85% completion by November 2021. In terms of overall integration, for the last 2 to 3 years, something that we're really proud of is that we all use the same case recording system, both health and Barnardo's professionals, and all of our family support work is integrated now. So across the BFS partnership at any one time, we work with around 700 open family support cases, but all of those come through an integrated allocations meeting that involves health and Barnardo's professionals, and is held on one recording system. So that, goes back to the point I made previously about families being only having to tell their story once, and actually professionals being able to see the work that's going on for those families to make sure we maximise the work we do with them. I think obviously we can't move away from the fact that we've all had a really difficult year in the last 18 months. And I think our integration has enabled us to respond really well to COVID. So to give you an example of that, because of the work we've got between professionals within the partnership, in the city, we were able to, in the first 3 months post-lockdown, issue resilience grants from Birmingham City Council in partnership with their response to over 800 families through BFS, and provide additional family support to 200 families in addition to our normal caseload. And also the partnership allows us to respond extremely quickly to emerging needs. So, for example, in line with national trends, we experienced a massive spike in terms of cases where domestic abuse was present during lockdown. But because of the partnerships we've got, we could respond extremely quickly to that. And we were able to quickly fund between the partnership specialist work via the partnership we have with Birmingham Women's Aid to provide additional IDVA capacity to work with our health and Bernardo's teams to train staff and pick up specialist cases. And we were able to quickly develop a webinar and training course between Bernardo's Women's Aid and BCHC, which was delivered to all staff about emerging themes around domestic abuse in COVID and how to deal with them. So that's just a few examples of a sort of not only being able to integrate, but also to quickly respond to changing needs. I think that's underpinned by really good communication. So obviously when we've got co-location, triage and co-referral of cases, that starts on the ground with professionals. But actually in the city, our partnership means we've got really good reach and comms. So to give you an example of the scale of that, you know, our newsletter is sent out to around 500 internal professionals within the BFS partnership each month. Our website in the last year has been at over 150,000 hits, and our Facebook pages across our formal BFS page and our partners pages have received over 500,000 hits in the last year. And what that means is that we've got really good local communication between professionals, but we're able to respond quickly and get out really key public health messages, home safety messages, and we are able to do that in a really coordinated way. So with all of this going on, what does that mean in terms of future opportunities and challenges? Well, I think that, you know, because we've got such a thriving partnership, I think an opportunity is to further integrate the added value that both ourselves as Bernardo's and our other voluntary partners can bring to the service. So if I go back to the example during COVID, where we allocated 800 families resilience grants in the first quarter, that was done in the context of also allocating over £9,000 worth of funding from the Bernardo's COVID Relief Fund, and also allocating around £150,000 through Bernardo's See Here Respond DFE funded projects direct to community organisations. So that was a prime example of looking at a citywide approach to an emergency where we as Bernardo has brought value to existing local authority funded systems. And it wasn't just the resource that was brought in, it was the triage and coordination, because we were able to look at it holistically as a partnership and make sure there was a lack of duplication and that resources were allocated in the right way. And I think there's a real opportunity to move that forward in the next 18 months. Both an opportunity and challenge for us in BFS is the 0 to 19 agenda. I think nationally, obviously, traditional children's centre work is being increasingly either integrated already or about to be integrated with a 0 to 19 approach, and that's going to be the same in Birmingham. And I think for us, we can see both real opportunities to do that in a coherent way, but also some challenges to make sure that the 0 to 5 specialism and the good work that we've achieved in that is protected and not too diluted. So that is both an opportunity and challenge in the future. I think that the examples I've just talked about obviously highlight the fact that because of the nature of our partnership, what we're looking at is the opportunity to actually influence a system-wide approach. And that's often talked about, but hard to achieve. So that's something that we've really got to think about moving forward. And I think that the sort of key to doing that in the future is making sure that we nurture the relationships we've got and don't lose them whilst expanding to meet challenges in the future. And I think that the sort of real strength and opportunity we've got to do that is that we've got a real strong infrastructure in terms of our governance, both strategic managers working together in partnership, but also operational staff on the ground.
And I think if I might just offer a...
Yeah, I had to remember two things. One is that the most recent questions are on the top of the chat, not the bottom. And that was a major challenge. And the other is to turn my microphone back on in between. We will have another Q&A session after the next presentation. Thank you for that from Birmingham. I'm just sitting here so pleased to hear about integrated services and bringing the three together that you talked about. It's just great. And I'm hoping that I'll be similarly entranced at what we hear from Essex, the Essex Child and Family Wellbeing Service. Adrian Coggins.
Thank you very much, Sir Michael, and thank you, Rukhsana, for inviting me to speak. So we've heard some really important, really depressing data this afternoon, and data is really important. It gives us the basis on which to act. Equally important is culture. Culture, I think, is the mechanism by which we act, and it's culture which is going to determine whether or not we take the collective approach that we need to take to achieve the outcomes that we want to. So I'm just going to thank you very much. So a couple of caveats. So I feel slightly fraudulent. I'm here talking about outcomes. I'm ashamed to say we haven't quite cracked childhood poverty in Essex yet, or we haven't achieved all the outcomes that we set out to do. It is very much work in progress, and it feels a bit more like the what's the phrase, the end of the beginning rather than the beginning of the end. And the principles I'm going to outline are my take on the world based on my experience. They're not fundamental truths, but they are absolutely heartfelt. So I'm going to distill in the short time I've got a very long and involved process into a couple of, I guess, defining moments within that process of getting to outcomes. So the first thing we did, we recommissioned. We had a number of contracts which were expiring, and we wanted to bring them together to recommission them in a more integrated way. So the 0 to 5 Healthy Child Programme, the 5 to 19 Healthy Child Programme, what were previously called children's centres, then became family hubs, as well as a direct entering into a direct co-contracting arrangement with one of our clinical commissioning groups for children's therapy services. But we did something very important. We didn't take the specifications that we previously had and say, right, so let's start with this and let's see how we can do a bit of continuous improvement. We completely parked those, and we started with a blank sheet of paper, and we got everyone in a room and we said, what do we want to achieve? And that was an incredibly powerful and profound experience. And when we combined what do we want to achieve with the statement of, by the way, there's complete freedom about how we achieve that. Nothing is off the table. It becomes even more profound. And we had some very grateful commissioners, some very grateful practitioners who really welcomed the opportunity to be given the freedom to think about what we achieve, and also to reflect on any discrepancy between what we were currently collectively doing and the outcomes we were setting out to do. So that was a fantastic experience. The second meeting was, I guess, not necessarily fantastic, but it was a different experience. That was deeply challenging. And I've used the word distressing. I think that's not overstating the point. So we can't just have an esoteric discussion that says we want to achieve these outcomes. Everybody wants to achieve good outcomes for children and young people. There is a need to ground those high-level outcomes in the reality of a contract where you hold a provider, or ideally a system, more on that shortly, to account for achieving outcomes. So what are good proxy measures of outcomes? Over what period of time? At what point does a proxy measure become a meaningless activity measure? And also, again, by starting with what do we want to achieve, doing a healthy critical reflection of some of the measures that we currently use, just because it's national policy doesn't necessarily mean we should uncritically accept it. Actually, what we should be doing, all of us, is doing a bit of critical reflection and, again, seeing what any discrepancy we think there is between some of the things that we have to measure and the overall rationale about why we are doing what we're doing. So here's just a list of probably the key outcomes that we came up with, and I'm not going to go through these in a huge amount of detail, but just to pull out a couple of them. So children and young people feel safe. All children and young people have strong attachment to at least one adult or other person in their life. And that last one I think is particularly important to me because we're mandated to deliver health visitor checks, which is the right thing to do. We want families to feel supported, but we have to think about why we want those visits to happen. What are the outcomes we want of those? And I would say an outcome that we all want is that children and young people have strong attachment to at least one consistent, significant, appropriate adult in their life. So why not be explicit about what we want? And why not try and find the best proxy measure we can of that rather than just accept what we currently have? And I'm very happy to share our detailed list of outcomes and key performance indicators after this session. So you don't need to look at the detail of this. This is just really to highlight that the detail is challenging, messy, and iterative. So it really shows you that if you start on the left-hand side with all children and young people have good emotional well-being, never been a greater need for that, obviously. So what is the measure that you use for that? Is there a good baseline that exists at the moment? No, in short. So do you put all the onus on the provider that you commission to generate a baseline? Is it a provider-only responsibility or a shared responsibility with commissioners to look at generating a baseline and which tools you use? Once you've got a baseline, what's the target? Do you expect 100% of children in the first year of the contract to have good emotional well-being? Probably slightly unrealistic. Where do you best put your effort in, say, a 0 to 19 spectrum? How often is that data reported? And what are the implications of non-achievement of those things? So the point here is the discussion on the sort of detail, like where do you put your efforts around emotional well-being? Who is responsible for doing what within the emotional well-being space of children and young people? That discussion, the quality of the discussion is considerably elevated when you get serious about holding people to account for the outcome. I think the other thing that we did around children and young people's emotional well-being, which hopefully follows on nicely from what others have said around looking at a broader determinants of health approach, is we got a few people together in the room. We said, what do we think are the determinants of children and families' emotional well-being? And as you can imagine, loads of people threw out loads of stuff. So we had a very full flip chart of all the determinants of emotional well-being. And then we looked at what we commission. And we commission mental health crisis services. We commission a bit of voluntary sector support here and there. We commission universal services, which has obviously emotional well-being as part of what needs to be done. But actually, the gulf between what I could evidence in terms of what we collectively commission and the determinants of emotional well-being was, as you can imagine, huge. So holding up that mirror to ourselves was actually a very useful process. So the first principle, begin with the end in mind. So as I said before, not starting with what we've got. And I think this is a key point for me. If you look at what you already have, that's really dangerous, because there is this kind of subconscious influence. It's quite kind of insidious, but it drives you to do more of the same or to do a bit of tweaking. I never assume that what we have is right. And as Sir Michael said earlier, so if childhood poverty and health inequalities are not getting any better, why would we want to continue doing what we're currently doing? So this focus on the outcome, this, I guess, internal debate about the discrepancy between the goal we want to achieve in our current practice, the rationale for why we're doing something and how we're measuring it, that's a really important principle to consider. So the second principle, think back to my public health training. I think this is probably the most important thing that my lecturer said to me, actually. Make the important measurable, not the measurable important. It's so easy to measure stuff that's easy to measure, but it's often a poor proxy measure. We're talking about long-term goals here. This is not an instant fix or a quick win, which is probably one of my most hated phrases. So we need to decide what milestones are at what stage. That is challenging, particularly in a clinical environment, a political environment. So I work in a county council, which is a political environment. I guess all our environments are political to varying degrees. So I am very lucky in Essex. I have some absolutely wonderful elected members who committed to a 10-year contract. Now, that is a major achievement. There is generally a resistance in the public sector to commit to long-term contracts because people think once you're in, you're in. Well, that's true. But what that means is you have to get it right. You have to commission right in the first place. The outcomes that we're looking at here cannot be commissioned in the short term. It's simply not long enough. And activity measures as a general rule, and I would question some of the activity measures that we are still asked to measure nationally in terms of universal services. And I would say they are not good proxy measures of the overall rationale about why we are doing what we're doing and the outcomes we want to achieve. So the third principle, just joining up previously separate services, that is not an outcome. If you just take what you've currently got and you aggregate it all up together, that of itself, I suspect is, well, I know it is not going to achieve the outcome. So if we're looking at a broader determinants approach, we have to think about who is best placed to do what. And I think something which is becoming really, really apparent to me is the utter interdependency between all the various variables that we think about in the wider determinants of health approach. So we're quite interested in the Robert Wood Johnson Foundation determinants of health at the moment. And they talk about 40% of the determinants of health being socioeconomic. So if that's the case, and I challenge myself as a commissioner of public health in local authorities. And if somebody came to me and said, Adrian, we can offer you achieving these outcomes if you give us all your money to look at, to put into the 40% of socioeconomic determinants. And I challenged myself to say, so would I accept that? And I hope I generally would. Now that's quite a risky thing to do. And that's very different from us commissioning traditional public health services. But if we recognise that interplay between those broader determinants, we have to have a much, much stronger relationship with the socioeconomic determinants. Specific interventions in isolation are limited, especially if they are if they're short term and there's a sort of a clear 3-month timeline, for example, where there's a pre-service evaluation and a post-service evaluation. Of course, that is part of an overall solution, but we shouldn't assume that, for example, a 3-month parenting program is going to produce an outcome of school readiness. And I'll just draw your attention to the quote at the bottom there. So I remember after a particularly challenging day as a parent, and I also commission weight management support. And I said, you know what, as well as obesity, sometimes it feels like parenting is a chronic relapsing condition. And by that, I mean, people need support over time. People need support over the life course. People need support over the life course as parents. But often we don't commission those that type of support. We commission services, the timescale of which is defined, and generally speaking is quite short term. And the fourth principle, be bold, bloody, and resolute. You have to be a bit of a maverick in this. I have been shocked, quite frankly, at the number of people who said to us, you won't do this, you'll never achieve it. You'll never achieve a joined up contract where you co-commission children's services with the NHS. Well, we did. And the reason we did was because we said, and this comes back to the cultural point again, we said, no matter what happens, we are going to overcome the obstacles to do this. And I'm so glad we did. The benefits, a meeting I will never forget when we were looking at the children's autism pathway, of having every practitioner, right from families at the start, right through to secondary care, all in the same room, all joined up, all having a shared level of accountability, rather than separate contracts with separate contract commissioning processes, and each person focusing in a slightly partisan way on their own particular part of the picture. And I think this is my last slide. So in terms of the future, so for me, I think the only game in town, if we're serious about this, is not individual contract accountability. It's shared accountability across a system, shared accountability for outcomes. So to give you an example, one of the outcomes that we've commissioned from our partnership of Virgin Care and Barnardo's in Essex is that all children are ready for school in advance of starting school. Now, my providers say to me, well, we'll absolutely do our best, Adrian, but we're not responsible for 100% of the determinants of that, to which I say, absolutely fair enough. But again, the act of me being serious around commissioning that as an outcome from my part of the puzzle, I hope going forward will drive others to who are commissioners for other parts of the system to also hold their providers to account for the same outcome. Now, of course, within that are parents. So do we hold parents to account for being part of the solution to this? That's possibly a little bit emphatic. It's probably a slightly different way of saying the same thing that Rukhsana was saying earlier about co-creation with parents. At the end of the day, there are a number of determinants of emotional well-being, of school readiness and emotional well-being. And we ignore any one of those determinants and our commissioning of providers who can fill the gap in those determinants at our peril. So I think shared accountability for outcomes across all stakeholders, not just individual contract accountability, has to be part of the way forward. And I really look forward to working with the integrated care systems in Essex to try and focus on those shared outcomes. Thank you very much.
Thank you very much. I didn't want to stop you, although you were running over, because I was enjoying it too much, but that wasn't a very good argument. But thank you very much for that. So let's move on. I do like the sound of something that's called HAPPY, Healthy and Active Parenting Program in Early Years, from Barnardo's, is that right? And Deborah Buxton is going to introduce it.
Hi, I'm Deborah Buxton, Children's Services Manager at Barnardo's. I manage several services, one of which is HAPPY. HAPPY is a commissioned service by Better Start, which is a lottery-funded organisation. We've been commissioned to deliver this in Bradford for a 3-year period. I will now hand over to Sonam, the team manager, who will tell you more about the programme.
Thank you, Deborah. My name is Sonam Bala and I'm the HAPPY team manager, and I will be talking about the Healthy Active Parenting Programme for the early years. The topics that we will cover today is the current challenge of childhood obesity in Bradford and the health inequalities related to this, what the Happy programme is about and the aim, how culture and ethnicity play a role in childhood obesity, the outcomes achieved from Happy and how Happy is evaluated, and the difference that Happy has made to those attending. So what is a challenge of childhood obesity in Bradford? We know that childhood obesity is a national issue. Data from the JSNA report in Bradford reports that whilst the average statistics of overweight and obese children in reception is closer to the national average, the rates of overweight or obese children in Year 6 are higher at 37.9% compared to the national average of 34.2%. There are early life risk factors for childhood obesity, and one of these includes maternal BMI. In the Better Start Bradford area, a quarter of pregnant women would be categorised as being obese. More than half would be considered as being overweight and obese. In addition to this, parenting indulgent feeding practices, sedentary behaviour and prolonged screening time is also a risk factor. Evidence suggests that breastfeeding can be a protective factor. In Bradford, the initiation rate and continuation of breastfeeding after 6 weeks is lower than the national average. The early introduction of solid foods may lead to rapid weight gain and increase the risk of childhood obesity. And research has shown that in some ethnic groups, the introduction of solids is earlier than the recommendations of 6 months. So what are the health inequalities that exist in Bradford? So Bradford is one of the most deprived areas in England, with 22% of children living below the poverty line. At least 25% of households in Bradford would be classed as low income, and the infant mortality death rate is higher than the national average. Research has found that there is a strong link between poverty and childhood obesity. So by the age of 5, it has been found that children in low income households are nearly twice more likely to be obese compared to their peers from a better socioeconomic background. Children who are overweight or obese are far more likely to suffer from serious illnesses such as type 2 diabetes, heart disease, and cancer later in life. So what is Happy all about? Happy is a 12-week antenatal and postnatal evidence-based programme. It was written by Born in Bradford and Family Links, and it's delivered by trained practitioners. The aim of Happy is to reduce childhood obesity within the Better Start Bradford area. The programme takes a behavioural change approach to improve maternal diet and physical activity, infant diet and physical activity, emotional health, and developing parenting skills. Happy has a focus on reducing health inequalities by providing a child with the best start in life throughout the promotion of breastfeeding, infant development, and a healthy lifestyle for the whole family. It is a targeted intervention at pregnant women with a BMI greater than 25. We work with a wide range of health and community professionals to ensure that the programme is well integrated into the community. So this includes midwifery, health visitors, perinatal coordinators, and community neighbourhood workers. For those harder to reach groups, we facilitate provisions for access into the programme. So this includes transport, translation, creche, and digital support. The programme is delivered in local community centres, and outreach and engagement is a key part of the programme to support both professionals and individuals in accessing the programme. So how does culture and ethnicity play a role in childhood obesity? While childhood obesity is high amongst particular groups, studies have shown that there are several ethnic factors during infancy which can lead to the prevalence of childhood obesity, which continues into later adult life. So for those of a white British ethnic background, these factors can be smoking, maternal BMI, breastfeeding for a short period of time, and indulgent feeding practices. For those of a Pakistani ethnic background, although the babies can be lighter in weight at birth, low parental warmth and greater infant sedentary time can lead to rapid weight gain. Bradford is very culturally diverse, and it's important to target these harder to reach groups. Throughout the course of delivering Happy, greater than 80% of those attending are from a BAME background. So what are the short and medium-term outcomes? From a programme evaluation on sample data until November 2020, results show that we have greater than 80% of women who are completing the programme, making healthier food and physical activity choices, not just for themselves, but for their infants and extended family, reporting a greater confidence with parenting skills. We have a higher rate of women reporting the introduction of solids at 6 months, and 100% satisfaction rate of those attending in terms of the content, accessibility and support provided throughout the programme. And what do we hope to see in the future with Happy? So we hope to see infants with a more healthier weight at birth, reception and year 6, which will be measured by the National Childhood Measurement Programme. We hope to see an increase around parenting, which will support perinatal mental health, and a whole family approach to healthier lifestyles. We hope to see an increase in maternal and physical activity and an increase in the confidence and knowledge of breastfeeding and the average age of introducing solids. We know that the causes of childhood obesity is due to several factors, and the improvement will be affected by a number of different interventions, of which Happy will be one. These outcomes will be tracked as part of the BIBS cohort, which is led by Born in Bradford. Evaluation will show whether children whose mothers have participated in Happy showed improved outcomes compared to those who did not. So how do we evaluate Happy? There are both quantitative and qualitative measures that are taken pre, post and during the programme. The quantitative measures include the mother's BMI, which is taken at 10 weeks gestation by a midwife. Postnatally, health visitors will take regular checks on infants for healthy weight gain and gross motor skills. There are qualitative measures that are taken around behaviour change, and these include pre and post questionnaires, which cover fruit and veg consumption, a 7-day physical activity recall, sitting time, and the breastfeeding intention and duration. Postnatally for infants, there is data that is collected on the duration of breastfeeding, age of weaning, and tummy time practices. There is also weekly participant and facilitator forms, which are completed after every session, which allows the programme to be continuously reviewed and ensure that it is appropriate for those who are attending. So what difference has Happy made to those who are attending? Humera is a second-time mother with an 8-year age gap between her pregnancies and was feeling quite anxious about her pregnancy. Humera joined the programme at the height of the pandemic and was feeling quite isolated. Throughout the programme, Humera felt more empowered to make changes to her lifestyle in ways that she would never have previously considered. Humera started to ensure that she was taking daily walks throughout her pregnancy and continued this postnatally. She would also take her elder child out for physical activity, as she saw the importance of this, not just for herself, but for her whole family. Throughout learning about healthy eating in the programme, Humera was able to share this information with her family, focusing on the Eat Well guide to help balance her meals, and Humera fed back that her son was now keeping her on track when she may have opted for an unhealthy snack. Prior to the programme, Humera had no intention to breastfeed, as she did not in her previous pregnancy. However, learning about the benefits of breastfeeding throughout the Happy programme and the support that was gained postnatally from the breastfeeding buddies, Humera was able to successfully establish breastfeeding for 6 months. So just on an end note, this is a baby fruit pram that we made for the launch, and we use this as an example throughout the programme to showcase that we don't always need cream cakes at baby showers and that healthy eating can be quite fun and creative. Thank you very much for listening, and if you have any questions, please feel free to contact myself or Deborah. Thank you.
Thank you. So you're making us all happy, I hope. And we want to move to economics. I've been arguing for a long time that we don't need to make the economic case for what we do. Improving people's lives, getting greater health equity is sufficient justification without making the economic case. I've been told that I'm living in an unreal universe. We have to make the economic case. So please, Rachel McKinnon, are you going to make the economic case for investing in family support?
Good afternoon. My name's Cathy Marriott. I'm the head of operations for Isle of Wight Children's Services. I'm really sorry I can't be with you this afternoon. However, we thought it'd be a good opportunity to share some of my thoughts in terms of the journey that we've been on in our development of family hubs and what are key to their success. So in 2014, we embarked on our journey, undertaking a public consultation, looking at how we could move to a family hub model with services for 0 to 19-year-olds based out of our Sure Start children's centres. What was really important was that we maintained the benefits of integrated working across health colleagues, across social care, with family hubs providing an integral part in terms of our early help offer. What has been particularly important about the model is that, yes, there are universal services delivered via our family hubs, but intensive family support forms an absolutely critical part of our early help offer through our family hubs. Being able to deliver that bespoke support to parents at an early stage has made a real difference in terms of preventing escalation of children's cases into children's social care, but also it allows us to step down children and families so that they are supported to return back into the community and into universal services. So for our money, it is absolutely critical that those services are within our integrated offer in our family hubs. We have 3 hubs delivering across the island. They link with all of the local voluntary organisations as well as statutory provision and are a key part in delivering early help assessments and plans. Again, that's stopping escalation into higher tier services. We have been recognised nationally as an early adopter of family hubs and are working with the Department for Education in terms of the development of that model going into other areas. I feel that they have been a really critical part of the success of Isle of Wight Children's Services. We have worked in partnership with Barnardo's, who are our commission providers for family hubs, in terms of taking learning from other areas of the country, but also promoting the learning that we have developed across the country as well. It's very much a joint enterprise. So again, apologies I can't be there. I hope you have a really good afternoon hearing all about the work that's underway on the island.
Thank you, Cathy. Hello everyone, I'm Rachel McKernan, Assistant Director for Children's Services across Hampshire and the Isle of Wight. I've been fortunate over the last 7 years to have been working in partnership with Isle of Wight Council to help them to bring their vision for early help, integrated early help through the network of family centres on the Isle of Wight to life. And as Cathy's mentioned, it works across the entire system, so from universal right the way through to intensive family support. And we also now support families who are having family time, supervised contact, with a view to providing parenting support to enable and facilitate reunification, should that be the ultimate aim. So things can change over time, and in a commissioning relationship, it's important that we're flexible. We've agreed on the Isle of Wight that there are 8 key early help enablers. So this underpins all the work that we do across early help. And while the actual deliverables may change, these are the principles on which we will work in partnership across the whole system. So this enables us to be flexible. When new priorities come out, when new funding comes down, we're able to look at how we integrate that within the entire wider early help offer. So this includes elements such as being trauma-informed and responsive, asset-based community development, ensuring our communities are sustainable and develop resilience, and supporting the wider early help system so that we get alongside those in schools and other children's services to enable them to develop the skills to be lead professionals and undertake early help assessments. So our partnership offer is very much one of co-production. So you'll see here in the middle circle, these are the elements that Isle of Wight Council directly commissions Barnardo's to deliver within the early help specification. And we've mapped this to the Thrive framework. So we work across getting advice and getting help and into getting more help, where our intensive family support sits. We recognise that universal offer is the way in which we ensure that everybody finds the right front door into early help. But we also recognise that it's the targeted intensive family support that enables families to make significant and sustainable change. And we also work at Tier 4 now in the managing risk with regards to the family time support, but also in terms of supporting step down from children's social care to prevent re-escalation. And Kathy spoke about that at the start. But around the outside of this picture is the work that happens within our integrated family centres, but aren't necessarily commissioned as part of that integrated offer. So this is where we, by means of partnership agreements, information sharing protocols, and joint steering groups, we work alongside partners to ensure that families can access everything they need from within their family centre. So all of our health visitor clinics and midwife clinics take place in the local family centres. We host play sessions from other providers, preschools, to support school readiness. We also work really closely with colleagues across health, so occupational therapy, speech and language therapy. Sessions are run in family centres, and often our targeted early help workers get alongside those and support families so that if they need additional support, there's a seamless transition into getting that either parenting advice or evidence-based parenting programmes, or indeed intensive family support. And then obviously we work in a more targeted area. So family centres host CAM sessions, speech and language therapy, and domestic abuse freedom programmes. But what we're really wanting to talk to you today about is the impact of intensive family support within a family hub or family centre model. We are required, because we deliver the Troubled Families, which is now Stronger Families programme, to monitor and track outcomes for families that we're supporting through intensive family support. But also across early help as a whole on the island, there is a distance travel tool attached to our early help assessments. So wherever a family is assessed within the children's service landscape, it would be the same early help assessment with the same outcome measuring tools. And that enables us then to look at cohorts of families and the impact that the services are making. We have 31 Stronger Families outcomes that we track on a 5-point scale, and that enables us to be very clear and evidence progress that has been made. So on this slide, you can see some of the outcomes that we can record and monitor. So you'll see individual outcomes for a young person, where we're monitoring 2 outcomes, and how that can be shown as a graph or as a reduction in scores over time. But you can also see how we can look at and analyse outcomes for an entire cohort. So of the families we supported last year, of all of the outcomes we tracked and monitored across all family members, 87% showed an improvement, 12% stayed the same, and we only had a decline of outcomes in 1% of the outcomes that we tracked and monitored. So here are some headlines from last year. 356 families received intensive family support, of which we had an engagement rate of 99.7% after 3 months. 87%, as you've seen, improved their outcomes, and we only had a 3% escalation rate to children's social care across those 356 families, which demonstrates that actually we are working with them to minimise risk and prevent escalation into children's social care. And really, holistic whole family support is the key to those improved outcomes. Our family practitioners work across intensive family support and evidence-based parenting programmes. And we have virtual lead professionals who share their skills and knowledge with a wider children's workforce to skill them up to undertake early help assessments, but also to scaffold them as they are lead professionals for the first time. So in 2021, the total costs of all staff and management attributed to the intensive family support element was 664k on the island, approximately 1,800 per family open to IFS. But analysis of the outcomes showed that for every £1 we spent, we made a potential saving of £2.60. That's equating to a potential saving of £1,062,400 this financial year. The full early help family centre offer cost 1.3 million. So the savings that we future generated via the intensive family support element alone would cover the remaining cost of the whole early help system service and family centres, and potentially still return a wider future saving of £427,000. And just to finish with a quote from Ofsted that recognise that family centres and early help delivered through family centres is the way in which we support families to improve their outcomes. Thank you.
Thank you. Your talk was billed as the economic case. I didn't get too much of the economic case, but that didn't bother me. What you're doing is so interesting. It relates to what I said in introducing it. The economic case is really perhaps not the prime case. The prime case is improving people's lives, which is what you were talking about. So thank you. We have a Q&A, and could I start by going back to Birmingham? And very interesting. I used to show a slide around 2010-11, after we did the original Marmot review, from Birmingham, the percent of children aged 5 with a good level of development. In the early 2000s, that percent of children aged 5 with a good level of development was lower in Birmingham than in the West Midlands as a whole. And it was lower in the West Midlands than it was in England as a whole. And between 2005 and 2010, the gap closed. And I said, wow, this is terrific. Birmingham closed the gap. And people said to me, oh, it's regression to the mean. Birmingham didn't do anything. What's happened? But that's old data now. That's 2010. What does Birmingham look like in terms of percent of children with good level of development at age 5 compared with England as a whole? And a related question, what about children eligible for free school meals? How are they doing in Birmingham compared with the rest of the country?
Crikey, there's a couple of kind of good and tough questions. I mean, one of the things about Birmingham-wide data is because Birmingham is very big. We serve 1.2 million people, and we've got some very affluent and some very deprived communities. City-wide averages often don't look too bad. So generally on those kind of measures, so Michael, we're not, we are below national average, but not kind of at the bottom of the rank. The insight I think for us though is that citywide average doesn't tell the whole story, and that if you look at some of the communities in East Birmingham, in places like Yardley, some communities in places like Ladywood in West Birmingham, some of the communities in Northfield, we see really high levels of deprivation, really high levels of kind of children growing up in very tough circumstances, and that shows itself in school readiness, and that shows itself in educational attainment. And people will know, we haven't cracked that yet in terms of the kind of work we're trying to do through Birmingham Forward Steps, but we're aiming at it. But it will take a multi-year concerted cross-city approach to make the kind of impact we need. I think the key message is kind of beware averages, really, as in the sense that citywide performance may not look so bad, but we've got some real communities who really need our concerted, integrated help.
I mean, and I want to come to Adrian in a moment. Adrian was suitably modest about long-term outcomes, that the ambitions were high. The long-term outcomes aren't there yet because they're long-term. There was a question in the chat about Birmingham, about your outcomes, and which, Richard, I think you replied to. But could you talk about how the programme is delivering?
Yes, so I think it's been, I will say, and it's not a secret, it's been a challenge, and some of the, like lots of places, we've faced some real kind of challenges with workforce and activity pressures, and so I want to be realistic about where we're at. I think we can show that against a number of those core measures of, do we know who the most vulnerable children are? Are we getting to see them regularly? Are we starting to improve the interventions we're providing? We can show progress. We aren't able yet to track that through to what you might call kind of end result outcomes. So I think we can show steady progress on the input and the activity. We are optimistic that will lead to impact on end outcomes in the way Adrian was talking about, but we are still a toddler, if you like, as BFS. We're a few years into our partnership, and we've a way to go yet, I think.
Thank you. Adrian, I think you generated, everyone generated a lot of interest, and there were questions. In a way, perhaps I could translate them by saying, you're a policy entrepreneur in Essex, and one of the problems with policy entrepreneurs is it's sometimes difficult to reproduce elsewhere. If people were excited by what you're doing in Essex, what's the message of how they could reproduce it elsewhere? How do you get long-term commitment? How do you get people to invest in this rather unconventional approach? How do you spread the word?
Thank you. Yes, I think I attempted to reply in the chat to a specific question, but just exposed my lack of IT skills, and it just went to the top of the chat. So, I mean, every area needs a maverick, I guess, but that's not enough. And I think that there's a real danger that the kind of discussion around partnership working together, integrated systems, that those are just buzz phrases which trip off the tongue. I think so. So the challenge is, how do we realise that in practice? And I think I could be wrong, but I think it's about getting some methodology that is specific enough for people to disagree with, which you can then replicate in all areas. So, for example, if we're looking at, let's take school readiness, for example. So I'm having a discussion in Essex at the moment to say, right, let's try and pilot a sort of multi-determinant approach in a particular area. And let's not do it across the whole of Essex. So let's see if we can agree with integrated care systems, with the voluntary sector, with other parts of the county council and the district councils. Can we agree to focus initially on a particular geographical area with a target cohort of people and make that a shared target cohort, a shared geographical target area, and to get everybody in the room to say, do we all want to see 100% school readiness? I would expect the answer to that to be yes. And then to basically say, right, let's do a bit of a, I mean, it's really not rocket science, I think. Let's just do a bit of analysis about what we think the determinants of good school readiness are. And let's list those in a column. And then let's list in the next column, who do we think can contribute to, who can have a positive contribution to each of those things. But where that is different than general partnership working is that the danger in general partnership working is that everyone gets in the room and says, this is what we're doing. And as I mentioned before, just aggregating that up is not going to look at the outcome. So I think we need some kind of framework which looks at the broad determinants, whether it's the Robert Wood Johnson Foundation approach or whether it's another framework which says, right, so if 40% of the determinants are socioeconomic, what's going on in the socioeconomic space in this target area? What's going on in the behavioural space in this target area? What's going on in the healthcare space in this particular target area? And I'm speaking to some very eloquent academics at the moment who are very keen on systems thinking and looking at kind of inference and estimation rather than causal attribution of particular interventions. And they are saying, actually, just start by listing what the determinants are and seeing if you can get somebody doing something in each of those determinant domains. But don't try and identify what the active ingredient is, because that's the point at which we might prematurely draw a conclusion. So that's only a partial answer, but I think, you know, there are some, for me, some clear next steps in that, in the process.
Okay, thank you. Can I just ask, what did you use? Your first word was culture. Did you mean culture among the deliverers of services or culture among the population? I missed it. What did you mean by culture?
So I'm talking about culture amongst professionals, so commissioners and providers of services.
Okay. In the chat, there was a cry of pain from a health visitor. Could I ask any of the panel from this afternoon where the health visitors fit into what you've been talking about?
Perhaps I might go first. Others might want to add. I mean, health visitors are a core part of what we're doing in Birmingham Forward Steps. They play a vital and valued role. I've heard the cry of pain from many of the health visitors we work with, though. Caseloads are high, the pressure is on, and I think the more we're all able to do to work through what role the important profession that is health visiting plays in these more integrated models as we go forward, the easier it will be for everybody to kind of work through their role. And there's a range of people on the call, I think, who are better placed than I am to speak directly to that. But I think we understand, certainly in our patch, our health visitors face an enormous amount of pressure, and I'm really grateful to them for the way they respond. And we're trying to do everything we can to build a clear role for them as an absolutely core part of our integrated teams.
Thank you. Matthew Clark, could I come back to you? We heard from Birmingham, from Essex, from Bradford about addressing social determinants of health, broader issues. It's personally what I'd like to see integrated care systems do. I provoked you a little bit at the beginning about why were you not talking more about things outside the healthcare system. Given what you've heard from Birmingham, from Essex, from Bradford, do you think there's more that NHS England and Improvement can be doing on these issues?
I think there's undoubtedly more we could do. I think that today's been a timely reminder of that. And as I sort of said earlier, I think my hope and an expectation really is that actually as integrated care systems start to flesh out how they're going to work locally. To a certain extent, some of that will be determined by the legislation that is ongoing for the care system. I hope there'll be more and more of an opportunity to do that. So I think this has, for me, been a really helpful reminder of how important that piece of work is. And as I say, I'm as interested about how we set up local structures to do that as sort of top-down policy directorates, which I'm confident actually often don't change things that much in a local setting as well. So absolutely, it's been a timely reminder for me this afternoon.
And I'm sorry, I left out the Isle of Wight when I was saying what we've been hearing. There was a comment in the chat about health inequalities framed around ethnicity, when in fact poor white children do poorly. I don't know if you had the same reaction I did when there was a House of Commons Select Committee report that said white children are doing poorly. And then I don't know who they thought they were talking to. And it's because of sensitizing everybody about racism. And that's why white kids are doing poorly. And I thought, what are they talking about? Well, this is complete and utter nonsense. Complete and utter nonsense. If poor white kids are doing poorly, that should bother all of us. And if Bangladeshi kids in the same level of poverty as white kids are doing better, we should A, be pleased that the Bangladeshi kids are doing better in poverty, and B, ask the question, why are the poor white kids missing out? I mean, I don't think we should be saying either we're concerned with poverty and social and economic inequality, or we're concerned with racial ethnic differences. Surely we should be concerned with both. And as we're in the last 5 minutes, I'll say it. I mean, there is a strong debate in the United States that's been concerned with these racial ethnic differences longer than we have in Britain. Not because we haven't had the problem in Britain, we've just been ignoring the problem. And there's a strong debate, and it turns out there's some research that shows if you present a problem and say, we're going to have family tax credits, if you present it to people and say, do you approve of this? And you do the experiment and you say, we're going to do it in order to reduce racial ethnic differences, or you present it, we're going to do it in order to reduce poverty, what you find is more people will approve of the policy if it's to reduce poverty than if it's to reduce racial ethnic differences. It's a bit challenging, isn't it? It's a bit challenging. And there's a real issue because it may be that a very important policy to reduce racial ethnic differences would be to reduce poverty. But then people say, oh yeah, but it's got to be oriented to racial ethnic differences. Yeah, but if it's oriented that way, then there's less public assent to it. Now, that's research from the US. I don't know if the same applies here, but we need to be thinking about those issues. Do we want, how do we go about framing our policies to reduce socioeconomic inequalities and to reduce racial and ethnic inequalities? They're not the same, but they overlap. And we need, I think, to be conscious of both of them. I mean, certainly, I think what we heard this afternoon was that integrated care systems can't address the tax and benefit system. Integrated care systems can't stop the Chancellor from cancelling the upgrade to universal credit. We need footballers for that. We need active footballers to influence economic policy and make sure children get fed. Thank goodness for 22 or 23-year-old footballers who are affecting national policy. Integrated care services by themselves can't do that. But what we've heard is there's a great deal that ICSs could be doing on the reality of people's lives beyond the core business of delivering care. And we've heard ambitious approaches. I mean, I presume that, taking the Bradford example, we know now that growing up in Bradford means growing up with relative disadvantage for all the kinds of things we've heard about. Ideally, if the program is successful, growing up in Bradford will not be associated with greater disadvantage. I asked you about Birmingham. Growing up in Birmingham in the 80s, or whatever you call them, the first decade of the millennium, was associated with disadvantage. That seemed to have been reduced. And that's what I was asking you about, an upgrade. And your response was, depends which part of Birmingham. It depends crucially which part of Birmingham. In the poorer parts, yep, it means growing up with disadvantage. And what we've heard is approaches to reduce that disadvantage. And it's been very encouraging. I think one of the themes that's come out of it is we do need long-term outcomes. We do need the measures of progress and hopefully of success, because it's going to be difficult to learn otherwise. We do need to push NHS England to take on the broader issues around the reality of family and children's lives. We do need to think about that progress through early childhood to adolescence to adult care. Been a very exciting afternoon, and I want to say thank you to all the speakers, to Barnardo's and GovConnect for organising this, and for the participants, the good questions and comments in the chat. Thank you all.